Welcome to our first Equip webinar of 2016. Welcome back. We're excited about the offerings that we have this year, so just a couple of quick announcements. We want to invite all of you that are in Washington State to attend our Equip conference, March 14th. That's a Monday. It goes right ahead of the Northwest Rural Health Conference. Very exciting offering. We are going to be talking about antimicrobial stewardship. We hope that you'll invite your hospitalist and clinical pharmacist to come to that. And we are going to talk in the morning about foundational information for antimicrobial stewardship, some refreshers on patterns of resistance, some refreshers on pharmacology, lots of good information. And in the afternoon, we're going to have a workshop where we will actually walk people through how to develop a plan for a small-scale stewardship program that will work in critical access hospitals. You will be seeing more information about how to register for that. This year it's $45 to attend, but it includes a fantastic breakfast buffet and a boxed lunch. So we hope that all of you will plan to attend. More information on that. In 2016, we are going to be focusing on developing webinars and educational material to help new infection preventionists and the experienced infection preventionists refresh on basic skills. And so today represents that principles of infection prevention, so that basic knowledge. My job today is going to be to try to keep you awake because we can only do so much with standard and transmission-based precautions, but we're going to try. So hopefully you've got your lunch. Got some caffeine on board, and we're going to get started. So, well, let me see if I can change the, okay, slide, housekeeping items. So you heard Jen, our producer, talk at the beginning about how to handle the webinar. I just want to reiterate that if you need to ask a question or if you want to make a comment, please, where it says send to in the chat field, do put all participants. Otherwise, I may not be able to see it, only the audience can see it. But you are welcome to ask questions. We'll have a time period at the end of this that will open the lines for you. So you guys know about Qualis Health. We are the quality improvement organization. We contract with Medicare. We do have some work that you may be interested in on our physician office side, critical access hospitals with physicians that are doing physician quality reporting. That's PQRS. Kelly Carnwath, our lead for PQRS, is available to help with that. Paula's going to chat in the chat box. She's going to put Kelly's contact information. So if you know someone in your hospital that is working on the quality reporting with the physician groups, please reach out to Kelly. She's very happy to help. So today we're going to go back to the basics, and we're going to talk about the chain of infection. We're going to try to talk about some of those risk factors that are associated with infection transmission, both in the community and in healthcare settings, and then talk about those evidence-based prevention practices that you'll want to implement in your own setting. All right, so to start out, let's talk about risk factors for infection. The number one thing we want to look at is the self, your own self. You have risk factors that are related to your own behaviors, your age, comorbidities, chronic conditions, your vaccine status and immune function. Some of the anatomical factors, for example, patients and people that have trouble swallowing are at higher risk for pneumonia from aspiration. Your general physical well-being, that is how you're, do you have good social networks and do you have good stress reduction coping skills? So these things all play a role in your risk for infection. The other thing to think about is your risk of infection from others. Now, if you're a school teacher or a nurse, then you know that you're going to come down with almost everything that you're exposed to, especially around children and other people. So, for example, we know all of those childhood illnesses that go through a community pretty quickly through the schools. That's a risk from others. From adults, you'll see oftentimes things like influenza, the common cold, norovirus, staph infections, all of these things that can be transmitted from other people. Now, I want to talk a little bit about some of the risks in the community, and we're not going to go through all of them. The reason I'm starting here is because as infection preventionists in critical access hospitals, you may be the only infection prevention resource for your entire community. And so part of the challenge in getting infection preventionists up and running is understanding all of the different risk factors and infection types that are out there. So some of those community-acquired infections that you want to think about are food safety. I know when I lived in a small town back in Texas, I worried so much. We had a drive-in called Sonic. I don't know if you all have those in your town, but I worried constantly that they were going to have an E. coli outbreak at the Sonic because it was going to affect our entire town. So this is just one example of a risk for infection in the community that you probably need to be concerned about. The other thing is you're going to hear from schools, law enforcement, nursing homes, churches, public health, a lot of things around food safety that you're going to need to be aware of. So whether it's E. coli, norovirus, hepatitis A, basic food poisoning, you may be contacted for information on how to handle that. The other thing we talk about is water safety. So think about cryptosporidium, like if it's in the swimming pool in your community, or if you do a lot of lake swimming, you could have that. Giardia is another one. What I don't have on here is which is kind of related to water safety, and that is all of the more recent infections associated with mosquitoes. Thank goodness in the Pacific Northwest we don't have a lot of issues, but it is something you want to be aware of. So, for example, we don't worry too much about malaria, but you could see a patient come into your hospital that's recently traveled with some symptoms of malaria that you would at least want to be aware of. We also do see some cases of West Nile. We know that we're starting to see Zika in the southeast part of the United States. Chikungunya may be one of those mosquito-borne illnesses that we'll see in the United States soon enough, and dengue fever, which seems to be moving north as well. Another thing is the personal hygiene. Whether it's staph infections that we're seeing that are community-acquired or urinary tract infections, all of these put people at risk for infection. Another thing that we have to talk about when we talk about community-acquired infections is unsafe sexual practices. So as you all probably know, we're facing in the United States, not quite to a crisis, but I think it's coming, and that is with drug-resistant gonorrhea and syphilis. We're also seeing hepatitis C. I think we're doing better with HIV, although I know that we are getting pockets more related to IV drug use than sexual practices, is my understanding, but it's still something to be aware of. And then, of course, we have human papillomavirus, which is another thing that we think about risk factors in the community. So this isn't all of them, but these are just a few of the things that you need to be thinking about. But as infection preventionists in the hospital, your area of expertise and accountability is around risks in the hospital and in the healthcare setting. So when we talk about risk, we're talking about the environment. That is water, air, surfaces, all of those fomites. We're talking about care and treatment practices. That's the hand hygiene, poor aseptic technique, the invasive procedures. What kind of are we doing INDs in the room? Are we doing surgeries in our OR? All of these have risks, including use of antibiotics. So even though we know that antibiotics we can never get to zero, and we don't want to, but use of antibiotics does put people at risk for other infections, including MRSA, C. difficile, vancomycin-resistant enterococcus. We have indwelling devices that we need to be worried about, including Foley's, central lines. What about injection practices? In hospitals, I think we've done a fairly decent job, but we still see in the news problems with medication management and diversion, for example, or fluids that haven't been managed well and are beyond their use date or have been contaminated. So trying to get a handle on how to look at these infection risks, you need to know about the chain of infection. And I will say that in the years I've been doing infection control, I underappreciated the chain of infection. It's something that is foundational knowledge. It's the first thing you learn as an infection preventionist. But when I have been faced with things that appear to be outbreaks, particularly around organisms that I'm not familiar with, I do tend to go back to this chain of infection and say, okay, what are we dealing with? How is it normally transmitted? So that we can begin to get a handle on, one, so I know where to go look for it, and two, how do I stop transmission? So while I know it's hard to appreciate it, this really is an important concept in infection control. And so I want to kind of go through each one of these. And I'm going to use C. difficile, because I think that's something we're all working on as an example as we go through this. So the first link in this chain is the infectious agent. There are some concepts that you need to know about this, and that is virulence, the ability for an organism to grow and to multiply. How invasive is it? That is the ability for the agent to enter the tissue. And the pathogenicity, and that's the ability to cause disease. So for example, Staph aureus, I know we're going to use C. diff in a minute, but think about Staph aureus. You know, if it's living in the nose and on the skin, that's fine. It's not pathogenic. But if it gets into your bloodstream, suddenly you have a whole different situation, even though that organism is not normally pathogenic. So these are some things you need to think about. What are the characteristics of the agent itself? The next thing we think about is the reservoir, and this is where does this organism like to live? Where does it thrive? What environment does it really take to have an affinity for, and where does it reproduce? So listed here, it could be living in humans, animals, insects, food, or the environment. We talked about the mosquito-borne illnesses in the community a few minutes ago. But if we think about C. diff, you know, not only is it, yes, the reservoir is humans, but even within the human, where do you find C. diff? We usually find it in the gastrointestinal tract, right? So these are things that you start to think about at an organism level. Where might we find it, and where would it like to thrive? So, you know, another thing would be if you have an outbreak of Pseudomonas. Pseudomonas is a water-loving organism, so the first thing you're going to try to do is go find where do you have standing water or liquids that might be a great reservoir for this particular bacteria. This is just an example of how to use this chain. Next thing is a portal of exit. So it's one thing to have an agent growing in its reservoir, but it has to have the ability to leave that area and then invade another space. So we think about the portal of exit. With C. difficile, the portal of exit, of course, is that watery explosive diarrhea. It lets those spores aerosolize into the environment. So that's a very dramatic portal of exit. But other things like influenza, we have the coughing and sneezing. With norovirus, we see vomiting. Some of the bloodborne pathogens, obviously blood, saliva, that kind of thing. And the contamination of the environment as well. So if you have something growing in a water bottle like Pseudomonas and that spills out, you have now had a portal of exit that you need to contend with. Transmission mode, many of these organisms are, you have to understand how they're transmitted, whether it's airborne, meaning that they're small enough to actually just float around on dust particles in your air where people can breathe it in. Droplet, where they may be a little bit larger and heavier, kind of wet, so that you have a 6 to 8 foot range from the person who is coughing or sneezing, where that can be transmitted to someone else. Contact, that's actually just by touch you can transmit this organism. Then you have the waterborne and the foodborne organisms as well. And so going back to our example of C. difficile, the transmission mode is contact. So you can just touch the spore and pick it up on your skin, and then the route becomes oral fecal. So you ingest those spores in order to be colonized with it. The next thing is that portal of entry, which I just alluded to with the oral fecal route, but you have to have a way for that organism not only to leave its reservoir, but to actually get into a susceptible host. And so what we think about in healthcare is medical devices, so those urinary catheters, those central lines, the ventilators. What about using instruments during surgery that may not be completely sterile? We also have wound care, dressing changes, all of those things that allow the organisms to enter a susceptible host. And then finally, we have the susceptible host. Now, it's really interesting that not everybody exposed to an organism is going to get an infection. And it really does depend on the person and how susceptible they are. And so much depends on, like we talked about at the beginning, that self and their ability to fight off infection. So anyone with that's immune compromised or stressed or anything that just puts them at higher risk may end up being infected. So now let's talk about that susceptible host. Again, we talked about immune function, the hospital care themselves, because frankly, if your folks are not getting health care, they're not going to ever be at risk for a healthcare associated infection. So those are the kinds of things we look at there. Environmental exposure, lots of things there. The other thing, not only are we worried about patients as infection preventionists, but we're also worried about our employees, because our employees are at risk not only of contracting infections themselves, but spreading infection to the patients that they care for. So in a susceptible host with employees, we think about, are they in contact with bloodborne pathogens? Have they been exposed, or do they carry tuberculosis? You know, what kind of, are they really good at adhering to the personal protective equipment and standard precautions? Would they recognize that they're at risk and take the right action? So don't forget your employees when you do your risk assessments. Now let's put this all together. So the chain of infection, as infection preventionists, we try to put barriers to each one of these links in the chain so that we can stop the infection. So things that affect the reservoir would be personal hygiene. If you can actually scrub the skin of organisms, then you have disrupted the reservoir. If you're looking at, say, Legionellas, we want to make sure that your cooling towers and anything that has the water that's heated to a certain level and distributed, that all of that has been checked and then the maintenance is done. Pest control is another way to disrupt reservoir. Portal of exit, cough etiquette, wound dressings, just actually covering it up can be helpful. We have hand hygiene, workflow being clean to dirty, and disinfection and sterilization is another way to stop the transmission. Portal of entry, again, we're talking about protecting ourselves or our patients through barriers, whether it's gowns and gloves, wearing masks, eye protection, skin care. And again, with susceptible hosts, vaccines is an important way to make a less susceptible host, creating work restrictions for your employees so that they don't come back to work while they're still shedding viruses, for example. If they've been exposed to bloodborne pathogens, making sure that they've got the right prophylaxis on board to make sure that they don't actually get an infection after exposure, and then some patient cohorting. So these are ways, again, of using the chain of infection to put in place disruptions of this cycle so that even though you have the infectious agent in-house, it doesn't actually make it all the way to an infection in a susceptible host. All right, so let's talk a little bit more specifically about some of the higher level practices that decrease the risk for transmission. Hopefully you guys are still awake at this point. When we talk about administrative practices, this is your infection control program. You really have to have the resources in place. You have to have good policies and procedures. You need to be monitoring the practices that you have put in place to make sure that they're actually being followed. Another thing is knowing what your high-risk procedures are in your facility. So are you putting in central lines? And if so, what are you doing to reduce the risk of central line-associated bloodstream infections? Same thing with Foley's, surgeries. We have quite a lot of bundle practices that I'm hoping later in this year we'll do some deeper dives on so we understand exactly what are in these bundles. And by bundle, I mean they're evidence-based practices that are used together to reduce the risk of transmission. So for example, in putting in a central line, are you doing full barrier precautions? Are you using CHG? Are you wearing a mask? Are you blocking off the room so nobody enters? All of these things work together to lower the risk on your high-risk procedures. I'm going to think about personal hygiene for your patients that are in there. What does that care look like? For example, we know that it's important to clean skin very regularly because if they have an indwelling device, any of the, just the regular skin-dwelling organisms that are normally not pathogenic, if they suddenly get into an indwelling device, is a real problem. So just by knocking down the load on the skin, you can prevent infections. There's a lot of ways to do that. We also know that good oral hygiene is an important factor for ventilated patients to keep them from getting pneumonia. And we also know that oral health is important for preventing things like cardiac infections. So you do want to, as an infection preventionist, understand the care at the bedside of these patients that may or may not have the ability to take care of their own personal hygiene. Another way is making sure that the patients are partners in their care, because you want to make sure they understand how important hand hygiene for themselves is, that they understand that healthcare workers that come into the room ought to be wearing certain barrier items like gloves, for example, maybe a gown if they think they're going to get exposed to urine or blood. So there's a lot of things that you can educate your patient about. And finally, we want to talk about healthcare practices, and that's going to move us into standard precautions. So standard precautions, this is the guidance that you really want to kind of have on your list of favorites on your computer. And if you have access to our SharePoint, you'll find a link to this on the page for today's webinar. If you don't have access to the SharePoint, feel free to email me and I'll get access to you so you can have that. But it's at the CDC site /HICPAC, and this is the one you really want. It's going to talk about standard and transmission-based precautions. So the first standard precaution that we talk about, cornerstone of infection control, hand hygiene. Now it sounds like hand hygiene is a fairly simple thing. It's something we've learned since we were, 2 years old. But it can be rather complex, and particularly adherence to it for healthcare workers. And we know that every single one of you is trying to monitor hand hygiene and trying to get it improved, and this is not as simple as it sounds. The standard precautions document talks about to avoid touching surfaces. Well, it may be very challenging if you're a direct care provider, but unfortunately, we know the surfaces in the vicinity of a patient tend to be contaminated. So if you can avoid touching those, that's a good thing. Wearing of gloves is something that's really important. How many of you know that at this point, alcohol-based hand sanitizer is actually the preferred method of hand hygiene and preferred by the CDC and the evidence? This is a myth that the myth is on soap and water being better than alcohol-based hand hygiene. So when you're doing education of your employees, let them know that alcohol-based hand sanitizer is better for their skin because it has an emollient. It also has more efficacy against a broader range of pathogens, the organisms themselves. Now, there are some exceptions, and we're going to talk about those in just a minute. Soap and water is appropriate, though, if you have visible soil on your hands. So if you look down and you can see that you have, something on you, you wash with soap and water and then followed by alcohol-based hand sanitizer. There are some other times when you would want to wash with soap and water. If you know that you're contaminated, even if you can't see it, like you picked up a urine, like a urinal off the bedside, without a glove, then you would want to use soap and water as well, followed by alcohol. Now, the exceptions are C. difficile and anthrax. So spores, right now, we don't have a lot of information about what will kill those spores, and that includes whether it's alcohol or soap. So soap does not kill, but it does have a detergent effect, which allows the detergent will actually allow the spore itself to not adhere as well to the skin, so you can just wash it off. So you just put it down the drain. You're actually just removing it and not necessarily killing it. But that's why soap and water is the preferred method. Norovirus is another one where soap and water is probably the preferred method, although some studies do show some efficacy with alcohol. In that case, it is better to do soap and water followed by alcohol. How many of you have a policy that prevents the wearing of artificial nails? This is something that's been recommended for a long time, I'm going to say at least since 2002, which is where these CDC guidelines come from. But even before that, in the late 90s, we know there were outbreaks in newborn nurseries related to nasty artificial nails that had stuff kind of growing up underneath it. So you're going to find in the guidance, it's going to say direct care workers working with a vulnerable population, but you might want to think about just not having artificial nails at all in case you have staff, especially in your small hospitals, that will float between areas. The World Health Organization has its own guidelines for hand hygiene. You've probably seen this before. This is the 5 moments for hand hygiene. And it's a lot. We don't normally monitor all 5. Usually we'll do a gel in, gel out as we're monitoring hand hygiene. But really, if you have C. difficile or if you have a MRSA outbreak or you have something that you just can't quite get a handle on, it is worth going in and watching all 5 moments for hand hygiene. And that includes before touching the patient. That's before doing any sort of invasive procedure. It's after the procedure, or if the healthcare worker has been exposed to bloodborne blood or body fluids. Then after touching the patient, and again after touching the patient's surroundings. So there can be a whole lot of hand hygiene opportunities in just doing very basic patient care. So think about how you might monitor that. Now, these are the World Health Organization guidelines. The CDC guidelines are slightly different. The main difference is CDC requires hand hygiene after removal of gloves. What we know from the literature and other studies is that healthcare workers that wear gloves feel like they themselves are protected, and then they don't remember to wash their hands when they take the gloves off. Now, if you've been doing infection prevention for any time at all and you're watching people, you know that when you take off gloves, it's almost impossible to get gloves off without contaminating your hands. It's just the physical act of it is very challenging. So CDC guidelines do add after removing gloves, and that should be part of your policy as well. Another thing that we talk about in standard precautions is the use of personal protective equipment. So yes, gloves are part of that, but we also think about wearing gowns. We talk about wearing eye masks or eye protection and surgical masks. The hard part about standard precautions is that for your healthcare workers, they have to anticipate the need. So it's not like every patient requires all the same levels of personal protective equipment. So there's some critical thinking that is involved. So if they're going to go in to empty the Foley bag, as this picture shows, really what kind of personal protective equipment should they be putting on before they enter that room in anticipation of a spill or a splatter or, as I have done, which is, you pick up that big container and the whole thing cracks and spills all over your scrubs and your shoes. So it's that anticipation that is really kind of challenging, and you need to be thinking about how to educate people for that. Standard precautions also is very hard, as we know from Ebola, the Ebola training, that it seems really easy to put on a glove and gown and a mask, but when you watch people, we just don't do it well. The CDC does have this poster, and this is just it's actually 3 pages, so I just grabbed the first part so you can see it, but this link, cdc.gov, HAIs, PPE sequence, if you're there doing new employee orientation and you're trying to teach people how to put on and take off their PPE, this is a pretty good resource for you. So I'm going to encourage you to go to this, check it out. This is not the Ebola guidance. This is just for your everyday standard precautions, maybe contact precautions. So just keep that in mind as well. Another thing that we talk about in standard precaution is respiratory hygiene or cough etiquette. I know you all have seen these signs. This particular one is based on the CDC guidance that came out probably in like 2007, I think. So it's been around for a really long time. It's very, very important that you have these up during cold and flu season, but really you could have this up year-round. Like I like to say, if you have people coming in and they're coughing, they're likely to be sick. So why not have them cover their cough? Now, this means for you that you want to make sure that all of those supplies are available where you have people either in your waiting room or nurse's station, emergency room, the entrance to your facilities. Make sure that you have the signs up so they know what to do and that they have access to the supplies. Another thing we talk about is patient placement. Now, this, as an infection preventionist, may be something that you should be involved in. With the bed board may already know some of this, but you're the expert on this, and that is knowing your patient's risks as they come in. This is not as easy as it looks either, because oftentimes you may only have one bed in a semi-private room that is it's considered a clean room, And then can you put someone who's colonized with MRSA in that room? So these are things that you have to have, again, some critical thinking about. Cohorting, there are some general rules, and this comes from the CDC. What we say first is that private rooms are always better for everybody regardless. So if you have all private rooms, good for you. You will not have to worry too much about this. If, however, you have one of those hospitals that has a mix of private rooms and semi-private rooms, now you have to really think about how are you grouping these patients together to reduce infection risks. So a clean room, if you think about that is reserved for people that are not colonized with anything. They have no history of infection. They don't appear to be infected right now. Maybe they're post-surgical with a clean surgery. These people you can put together. Then you have what I'm calling it a dirty room, but I put it in quotes because they're not really dirty patients. It's not a dirty room. The room has been cleaned, but the patients themselves are either currently infected or they've been exposed to something and are likely to come down with the infection. So those people you want to try to keep together. And once you get them together, you want them sequestered away from the clean patient, the patients that have not been exposed. So this can take some real thinking. You got to sit down and consider the layout of your hospital, know what your risks are, and good communication with the people that are assigning rooms, so the charge nurses on your area. And we could talk more about this at a future time or later today if we need to. So the other thing we talk about, standard precautions, are those environmental practices. Housekeeping. Later this year, I think I have it down in March, but we're going to do a whole hour webinar on housekeeping and what should you be looking for as the infection preventionist to make sure your housekeeping and environmental services is adequate for infection prevention. But some of those things that you're going to be looking for in housekeeping is, making sure that there's prompt removal of blood, bioburden, body fluids, that the right agents are being used at the right time. And how would you know? Like, as an infection preventionist, how do you know that the agent that our housekeepers are using is right for the job that they're doing? And we're going to talk about that in our next webinar as well. For housekeeping, you want to look at toys. This is another thing that crops up. Do you have toys in a waiting room, or if you have a pediatric unit, what kind of toys are provided there, and how do you get them clean? So you have to have a very strong toy policy as well. There's a lot with housekeeping that you need to know about because it is fundamental to infection prevention. Engineering is another thing. So we talked about the risks related to your environment, whether it's your HVAC system, your water systems, your wastewater systems. All of these things do play a role in the ability to transmit infections. So you do want to know that you have preventive maintenance being done. When you do your risk assessment, do consider these systems. You need to have a really good relationship with your plant ops people, that is your facilities folks. If you have to take them out for coffee, buy them enchiladas every Friday, whatever it is you need to do to have a great relationship with your facilities people, it is worth doing because you can get them to be infection preventionists and they can take you up on the roof with a hard hat and teach you about the air conditioning system. So that is a great relationship to cultivate. Think about central supply. That's another thing that is really important as far as environmental practices. Those instruments and things that are reused, are we removing the bioburden appropriately so that they're safe for reuse and for storing? So that's an important thing. And we've talked a little bit about high-level disinfection. Later in the year, we're going to have a whole webinar on sterile processing that's going to help do a deeper dive on this. But just know that dirty instruments do pose a risk for your environment and that there is certain work practices that you need to be aware of that can reduce that. Laundry, we always worry when Joint Commission or the Department of Health is in the house, everybody runs around and they cover up the linens. And there's a good reason for that because we know that the biggest risk to contaminating laundry is those dirty hands as you're rifling through looking for that extra large gown and you can't find it, and so you pick up everything that's in there. So it's the contamination with those epithelial cells, whether it's in passing by or rummaging through it. Splatter, for example, can happen up into your clean linen. So just know that is a risk as well. And then how do you handle soiled linen? So when you're changing the bed, making sure that you don't agitate it so all those C. diff spores don't end up, aerosolized in your room, or that you haven't contaminated your scrubs by hugging the dirty linens up against your body as you take it over to the basket. And then finally, you need to look at dietary. I mean, many of us don't even consider going down to the kitchen and having to look at all those refrigerator logs, and is everybody wearing their gloves, and what are those foodborne risks? But as an infection preventionist, you do need to know that that's part of your responsibility to make sure that the food safety is in place. And for example, with the care, how many of you have a policy on how long a tray can remain at the bedside of a hospitalized patient? You know, you come in, they're sleeping, you don't want to wake them up, you set the tray at the bedside, and then like 6 hours later, they're up eating lunch. So think about, do you have those practices in place around food safety? Standard precaution also has a lot to do with safe injection practices. Now, there is a great reference that I want to share with you, and that's the One and Only campaign. Everything that you ever wanted to know about safe injection practices practically is on this website, but it has very, very good educational material. So if you are doing, again, new employee orientation, annual infection control education, whatever that is, try to go to this site and see if there's anything on there that you think would be helpful to you. So when we talk about safe injection practices, first of all, it's aseptic technique. Are we accessing those vials appropriately with clean hands, in a clean environment, in a segregated space like a med room, so that there's no possible way that we've contaminated a vial? So aseptic technique. I think many of us on the call know that you can't reuse syringes. This is kind of a practice that perhaps in the past, this is something, if you just change the needle, you could reuse a syringe, but this is not a good practice anymore, and we know that this is a risk for all of the bloodborne pathogens. And yet, just recently, like within the last 8 months, we know that we've had huge outbreaks and investigations associated with vaccine lines that a nurse was just changing the needle. She was reusing the syringe to give flu shots. So that was kind of a big aha moment for those of us in infection control, that this practice still goes on. And obviously, we're not going to reuse needles. We're also not going to use common flush bags. Now, in hospitals, we don't see it a lot, but you do want to make sure if you have an infusion center or an outpatient surgery center that there's no common flush bags. Now, where I have seen this is in oral surgery, for example, where you have a very quick turnover. You got every 15 minutes they have a patient coming in, they start the IV. They had a common flush bag of normal saline. This is a huge, like 3-liter bag that they would, just hook people up to. So we know that that's not a good practice at all, because again, the bloodborne pathogens can back up into that tubing. Single-dose vials, single patient. It doesn't matter what size the vial is. A lot of times people will say, well, there's just, obviously this is not single dose because it's huge and you can use it for a lot of patients. Here's the thing about single-dose vials. What makes it single dose is it has no preservative in it. So according to the USP 797, if the vial itself does not say multi-dose, you have to assume it's single dose and does not have adequate preservatives in it. So that means once you've accessed a single dose vial, it can start to grow bacteria within 1 hour. That means once you've punctured that, you have 1 hour to use the medication in that vial or dispose of it so that it doesn't become contaminated. So those are the rules that you need to think about and the risks. Multi-dose vials, again, we know typically most of them have a 28-day beyond use date. So once it's opened, you can label it for 28 days. However, you have to protect that multi-dose vial from contamination. What the USP 797 and the Safe Injection Practices document says that a multi-dose vial cannot be used in a patient care area. So if you take a multi-dose vial into the vicinity with a patient, you need to treat it like a single dose and dispose of it immediately following that activity. This is because, and I've seen this, it is really easy for you to kind of double dip. That is, you use a syringe and a needle, draw up some medication. Lidocaine is the biggest culprit here for a procedure. they're injecting the patient. They need a little bit more. They'll hold up the multi-dose vial and go back in with the used needle and syringe to get just a little bit more lidocaine to inject. It's a multi-dose vial. Oftentimes someone else is cleaning up after the procedure, and that vial will then either go into a drawer, it'll go back to the med room, but it is now contaminated with bloodborne pathogens, potentially. So again, that's why we keep the multi-dose vials away from the patient care area, just so that we're not grabbing it with dirty gloves, and we're not double dipping. If you're doing any kind of spinal or subdural injections, a standard precaution now is to make sure that a mask is worn. So if you're doing, the big one here is labor and delivery. We do know that this particular rule came out of an unfortunate outbreak where either an anesthesia provider doing epidurals on women in labor. The women developed spinal abscesses, and I think several of them died. But when they did they epi-linked the organism, and they actually linked this particular provider's oral flora to the infections. And so from that, they said if you wear a simple mask while you're doing these procedures, that should be enough to protect your patients. So again, this is a great opportunity for your infection preventionists to go and kind of watch some of those procedures. Just make sure that the providers are wearing masks. Same thing with lumbar punctures in the ED. Point of care test, this is like the perfect place for Joint Commission or somebody else to cite you, because when you're using the AccuChecks or insulin pens, insulin pens should be single patient, so don't share those at all with any other patient. But your AccuChecks need to be, we know you're going to change the lancet between patients. I hope everybody knows that. But did you know that that machine has to be cleaned? It needs to be cleaned according to the manufacturer's documentation between every patient use. So that is something I think is a little bit, maybe not new, but overlooked. So when you're doing your rounds, that's something you want to make sure that there is some sort of cleaning of that device between every use. So those pre-meal AccuChecks are ripe for monitoring there. All right, so now as we talk about transmission-based precautions, and I know we're getting close to the end here, so hang with me. If you go to the same document, but you go to Appendix A, again, this is from that HICPAC guidelines for isolation precautions, Appendix A, and hopefully you can see it here, but this is sort of like the little Bible of what kind of precautions you need to put in place. We're talking about contact precautions, standard precautions, airborne or droplet. And it'll have on the left-hand column the infection or the type of condition that the patient has, the type of isolation precaution you want to put that patient in, how long they need to be under those precautions, and then some comments. And what you're going to see here is C for contact, S for standard, A for airborne, D for droplet. Duration, you'll see where it says DI on here, that's duration of illness. So for example, if this person has a draining major abscess, as long as they have that abscess, they need to be in contact precautions. The DE stands for decontamination. So in this case, if you have anthrax and you have the environmental spores that have landed on all the surfaces, then you want to make sure that someone is that there's precautions in place until it's been decolonized and decontaminated. So this is a great document. It's several pages long. There's keys down at the bottom so you know exactly what it means, but it's great. Now, this does not necessarily apply to the MDROs, which we're going to talk about in just a minute. Let's go back to what does it mean for contact precautions. So for certain infections, for example, methicillin-resistant Staph aureus, what we call MRSA, or VRE, which is vancomycin-resistant enterococcus, C. difficile, any diarrhea of unknown etiology. If you don't know what's causing the diarrhea, you might think about contact precautions, especially if your patient is incontinent, or if you have draining wounds that cannot be covered. You need to think about contact precautions. We already talked about patient placement. Private room is your best bet. If you have to cohort that patient, you want it with someone else that's likely to have the same illness. So if you think this is a draining wound from MRSA, maybe put them with someone else with MRSA. All healthcare workers, everyone entering the room should wear a gown and gloves. And I think the evidence is definitely for gloves. Gowns is iffy, but for now, we really do want gowns and gloves. That's what the CDC guidelines recommend. Patient transport, you do want to, when you transport a patient on contact precautions, you want to put the gown and the gloves on the patient if you need to, but the healthcare worker themselves puts on the PPE, assists the patient to either the stretcher or the wheelchair, and then takes that off so that you're never walking down the hall with potentially contaminated PPE. Again, it's very easy for people to feel like they are protected, and they're wearing their gloves, and who knows what's on those gloves. They reach out, they're grabbing doorknobs, turning on lights, assisting other people. So your policy really needs to be that the transporter does not wear their PPE in the hallway. You should always, in a contact room, if you can, use disposable equipment. If for whatever reason you cannot use disposable equipment, everything that goes in and out of that patient room needs to be terminally cleaned, really, between patients. So even if they're not on isolation, you're going to clean between patients, but if they're in isolation, you have to do an even higher level clean on that with the right product. Droplet. So droplet is this is the respiratory stuff that we tend to think of. So if you suspect meningococcal meningitis, influenza, pertussis, strep pneumo until there's been effective treatment, these are things you want to put into droplet isolation. That means basically standard precautions apply. If you anticipate getting, blood, body fluids, saliva on you, you want to wear everything. But in this case, and not just gown and gloves, but you want to add a surgical mask. This will protect your own respiratory tract from any of these infections. Now, if you are going to be in there doing an aerosol generating procedure, you might want to consider adding N95 to your regimen for droplet precautions, particularly influenza, some of those that are highly contagious and you're susceptible. For example, if you haven't had your vaccine, consider N95. Now, if we have an outbreak of something unusual, like SARS, like we did in 2003, MERS, this is that the Mediterranean coronavirus that we're seeing. We had quite a lot of cases last year that seems to be dying down, although I just read that a couple more cases have come in from Oman. Not in the United States yet, but who knows. So if we have an outbreak of an unusual organism, we just want to follow the CDC guidelines and just be aware that those may change daily until they figure out exactly what our best method is. We learned that from Ebola, but don't just rely on your normal droplet precautions on these. You really do want higher level expertise on that. When you're transporting a patient, put the surgical mask on the patient so that you as a healthcare worker, your transporter, does not wear PPE in the hall. Again, you can protect people by having the patient wear that. Airborne, tuberculosis, measles, chickenpox, disseminated shingles. These are the big ones that we think about for airborne. This requires a negative pressure room, so you would put your patient in there. You need to check to make sure that that room is operating properly. When we talk about negative pressure, if you think about this is how I remember it. A negative pressure room sucks, and a positive pressure room blows. So just think about that. That means that the negative pressure room, you're putting your tuberculosis patient in there, all the air is being sucked into the room from the hallway. What that does is it prevents that coughing of the very, very small particles of infectious material from floating out into the hallway because the airflow is inward. So it keeps those airborne contaminants inside the room. So you want to make sure that that room is working properly. So you need to make sure that the air changes are proper, that you can hold up like a little tissue by the door to make sure that the tissue gets sucked into the room. That's just a down and dirty way of knowing what your pressure gradients are. Personal protective equipment. This is where you need to have that fit-tested, NIOSH-approved N95 respirator. So as infection preventionists, you're probably involved with employee health, getting everybody fit-tested for your potential TB patient. This is the time you want to use it. Even though they're in an airborne room, you need to be protected from TB. If you need to transport that patient for any reason, again, we try to keep them in the room and have people come in to do all the work, but if you have to take them down for MRI or whatever it is, just put a regular surgical mask on the patient. They don't have to have an N95. In fact, they have not been fit tested for an N95, and the last thing you want to do is put those N95s are hard to breathe in. The last thing you want to do for someone who's already in respiratory distress is to put an N95 mask on them. So just a regular surgical mask, even though they have TB, the evidence that we're seeing in the literature says that because it's so close that it's enough to keep that TB or measles or whatever it is from becoming airborne if it's blocked at the nose and mouth of the patient. If they have skin lesions, so disseminated shingles, tuberculosis, whatever it is, cover those up when the patient is in the hallway so that there's no drainage that can get into your environment. And again, your transporters do not wear PPE while they're in the hallway. Okay, very quickly, multi-drug resistant organisms. Basically, your multi-drug resistant organisms are difficult to treat, and so we look at them in a special way, although I will say my personal take on this is infection is infection, and I don't want any of my patients to have MRSA that they caught in my hospital, but I don't want them to have, susceptible staph infections either that they caught in my hospital. And basically the infection prevention and controls that you put in place for MDRO are the same as contact precautions. We just treat it a little bit more special. So the things we're worried about are MRSA. We've already talked about that, VRE. And this other class of resistant organisms we call ESBLs, which stands for an extended spectrum beta-lactamase producing gram-negative bacteria. So that's a big old mouthful. We just call them ESBLs. So they are resistant to one or more classes of antimicrobials. Now, you've probably seen in the news a lot of excitement about the CRE, the carbapenem-resistant Enterobacteriaceae. That is one of many, many ESBLs that we're worried about going drug resistant. There is a different document that you're going to be looking at for the guidelines on that. It's this one, Management of Multi-Drug Resistant Organisms in Healthcare Settings. There's the link for you. Now, many people feel like because the guidance from CDC says if you have a multi-drug resistant organism infection, if you're colonized with it, if you've ever been infected, then they need to go into contact precautions. But really what this document says is that the interventions are put in place for those organisms that are judged by an infection control program to be of special clinical and epidemiologic significance. So for example, if you have a lot of MRSA in your hospital and you've got maybe some transmission, then MRSA is probably something you do want to control. You may not have any MRSA. You may be raging with C. diff. So C. diff is the one you really want to focus on, or maybe it's VRE. So my point here is that you really have to do a good risk assessment. You have to know what organisms you're seeing in your hospital, and you need to have a coordinated approach on how you want to control that. So again, in your facility, know the type, number, and the rate of all of your MDROs. You can work with your lab, you can work with pharmacy, try to get this information so that you can inform your risk assessment. You need to know who's vulnerable. So if you have a burn unit or if you have a NICU, I don't think our critical access hospitals have burn units, but if you have, say, a transplant unit or an oncology unit and you're worried about those patients, then maybe one case is enough to cause you to put a lot of other interventions in place. But you also need to know your antimicrobial use, what's your rate, colonization versus infected. So you just want to look at it whole house, and you want to look at it in a comprehensive way to understand where your risks are and what you need to put in place. Again, much the same as we've already talked about. Education, a little bit of that stewardship, making sure we're using the antibiotics correctly. How are you doing your surveillance? Do you need to step up your environmental cleaning? Do you want to try to decolonize your patients? Is standard precautions enough? Do you have to have everybody in contact precautions or just certain people, and when would you put that in? And do you want to institute active surveillance cultures? This does add quite a lot of cost to care, but it may be something you need to think about doing in a systematic way in order to get a handle on your MDROs. Now, a lot of controversy about when do you disconnect or discontinue your contact precautions. Well, really, there's no guidelines out there, but generally, if the patient has not been on antibiotics for more than 2 weeks and they have no other method of transmitting organisms, meaning the diarrhea has resolved, they don't have a draining wound, they don't have a lot of respiratory secretions, and you're able to do 3 or more surveillance cultures performed over a course of 1 to 2 weeks, and they're all negative, then you can consider taking them out of contact precautions. Again, depends on your risk assessment and your policy. But this seems to be the consensus. So once you do take them out of contact precautions, they've been in your hospital for 3 weeks, like your swing bed patients, for example, take them out, move them to a new room, terminally clean the room they were in, but give them all new supplies. So you're basically resetting their environment into a clean environment. But again, it depends on your policy. So I know we went a little bit long. I don't have a ton of time for questions, but I'm happy to entertain them. I know we've booked this to 1:30, but I'm ready to answer questions. And I also do want to say that at our next webinar, we're going to talk about the role of the infection preventionist. That is, how do you monitor these things? What should you be looking for? How do you write your policies to make sure that these foundational interventions are in place? So with that, I'd like to take some questions.
Great, thank you. Ladies and gentlemen, just as a reminder, if you wish to ask a live question, please go ahead and use the raise hand feature located under your name on the participants panel on the right to alert us that you would like your line unmuted. We'll unmute your line and you're able to ask your live question. If you don't see a phone icon next to your name, we are not able to unmute your line, so please go ahead and submit your comments or questions in the chat panel, and please be sure to address all participants. It looks like we do have a hand raised now. I'm going to go ahead and unmute Marissa's line. Please go ahead with your question, Marissa.
Can you hear me? I'm sorry. You know what? I got disconnected earlier, and I raised my hand then. It was a mistake. So I apologize. Thank you very much.
That's okay, Marissa. Thank you so much for joining us today. While we're waiting for the next question, I do see something came in the chat. The question was, if contact precaution patient is being ambulated down the hall by the PT, I think that's physical therapy, do the PT aides wear gown and gloves since they are in close contact with the patient? So it depends on your policy and kind of what's happening with the patient, why they're in contact precautions. Like if they're in because they have C. diff, not necessarily. We would want to think about ambulating that patient, particularly if they're incontinent. But in general, if you can get the gown and the barrier precautions to the patient, that may be something to think about. But what we really don't want to have happen is anybody in the hallway that's contaminated because they can contaminate the environment as well. I don't know if that answered your question, but it can be very challenging. I see also Sarah Podzervensky has asked this question: what type of hand hygiene method is recommended for norovirus? So currently soap and water is recommended for norovirus. Again, the evidence is sort of iffy on what is most efficacious. That there are some, it does appear there's some alcohol-based hand sanitizers that are effective against norovirus, but not all of them. But right now, soap and water is the preferred first line for norovirus. Jen, do we have any other hands or questions?
We do not at this time.
Okay. Okay, so while we're waiting for any last-minute questions, I know we're at the top of the hour. At our next webinar, February 23rd, we're going to come back and visit again some of these topics and really looking at the role of the infection preventionist. So a little bit deeper dive into what you need to be thinking about and how to write the policy. But also, if you have questions, if you have some case studies, if you have some pictures of situations that you want some advice on, send them to me between now and then, and we'll do some case studies. We'll all talk about this together and try to learn more about how the role of the infection preventionist can be applied in your setting. Okay, I see a question from Brandy Mendiola. Speaking about multi-dose vials, what are your thoughts on using a multi-use inhaler on multi-patients, changing the spacer between patients? We do know that a lot of hospitals are doing that, so it's a great way to save money. The spacer itself being changed, that's the real risk. And you do want to make sure you have to have a very strong policy on hand hygiene and cleaning that inhaler between patients. So I just recently, I would say in the last 6 months, had to do a literature review for that very same question. It does appear that that can be done safely, but it takes a lot of education and a lot of monitoring. What we're finding is that the number one way that those inhalers get contaminated is from poor hand hygiene. So if your respiratory therapists are very, very, very diligent, then it can be done safely. Thank you for that question, Brandy. Roxanne Huddleston says, when you have a new provider to organization to the ER with a history of latent TB, how often do you do a chest x-ray? So that's going to be an employee health question. My understanding is latent TB don't necessarily do any more chest x-rays unless they develop symptoms. So you might want to do a baseline chest x-ray once, and then you have them fill out a questionnaire making sure that they haven't developed night sweats, that they haven't developed a cough. So those are the kinds of things you'll want to work with public health on. But latent TB is not necessarily, it is not infectious until they become symptomatic. So, and you don't want to be bombarding them with x-rays every year either. We now know that that's over testing. Martha has a question that came in to all attendees. When you have a new provider, no, I think that was the second. Oh, that was Roxanne's question. Thank you, Roxanne. Thanks, Martha. Okay. All right. Thank you so much for sticking with me. I know this wasn't the most exciting webinar we could have done, but it is an important information. And again, throughout this year, we're going to be doing deeper dives. We're going to look at, again, housekeeping. We're going to look at those environmental issues that are infection risks to help understand what you need to be doing as the infection preventionist. We're going to look at some of the microbiology. So we have some really good offerings this year, and we hope that you'll join us for all of those.